What could an independent panel on action against antimicrobial resistance, or short IPEA, look like? Our recent research proposes 2 design options for what this could look like, based on lessons learned from the independent panel on climate change. Let's take a look. First, we have option A, which takes an intergovernmental approach. Similar to the Intergovernmental Panel on Climate Change, under option A, member states would be responsible for the establishment and funding of IPEA, as well as responding to reports and implementing recommendations. Member states would also be responsible for selecting the expert panel, working groups, and establishing a secretariat to facilitate the implementation of IPEA and its recommendations. In this design option, the expert panel would be made up of AMR experts, carefully selected by the secretariat based on their expertise and diverse perspectives across One Health disciplines. The expert panel would ensure the continued oversight of IPEA, identify any potential issues, and aid in the translation and implementation of the policy options developed by the working groups. Finally, the working groups and support units would assess existing AMR research, identify policy options, and build a much-needed evidence base on AMR. Alternatively, option B takes a more independent approach that is not intergovernmental. This option is a fully independently funded panel. Instead of member states, a board of governors made up of high-level AMR leaders and scientific experts would serve as advocates to accelerate the adoption of policy recommendations. In this model, the editorial expert panel would be selected based on expertise and equity criteria, limiting political influence over the selection process. This panel would be responsible for the coordination of activities, development of policy recommendations, and communicating findings to AMR leaders and groups responsible for implementing the recommendations. Under this model, an independent network of AMR experts would synthesize evidence and identify policy options. This AMR evidence collaboration could be built on existing structures such as WHO, WOA, FAO, and UNEP collaborating and resource centers in AMR, or relevant Cochrane collaboration centers. No matter which model is ultimately selected, there are key design considerations that must be thought through when building the IPEA, for instance, centrally integrating equity in the design. This could be achieved by ensuring equitable representation by AMR experts from low and middle income countries and across relevant One Health disciplines. At the AMR Policy Accelerator, we will continue our research efforts to inform the IPEA's design as it takes shape in 2025.